Good morning. It's 10:30 and we want to get started on time so we have adequate time for the presentations and for discussion at the end. So those coming in will, I'm sure, continue to file in, but we'll get on with the program. So my name is Wendy Nicklin. I'm the President and CEO of Accreditation Canada, and I'm honored to have been asked to moderate a session, so here I am. And being in that role, I was privileged to receive a copy of all the presentations in advance. So you're in for a really good period of time for just some fantastic initiatives that are going on across our province by your colleagues. Just a few things I will highlight, and then we will get started. I just wanted to highlight the call for abstracts. And you'd be interested to know there were 242 that were received, and there was a review committee. For the first time, there was patient on the review committee. So I think it's a really good testimony to that focus which you and I all increasingly have on the healthcare and all aspects of healthcare and quality. So that was really a critical element to make a difference. And the best abstracts obviously came to the top. The theme for this particular session tends to be around data and technology. No question when you look at it, it is all about improving quality. And you're going to see some remarkable evidence of initiatives which hopefully you can take back to your own organization about how to continue to raise the bar in your own organization. So the theme which you're hearing more and more about is that of spread, and I think some of the comments made earlier this morning about spread are very important, and how do we share learning. So it may not be that we're going to duplicate or replicate what someone else has done, but no doubt there's incredible learnings that you can actually take back to your organization. This is quite a well-oiled machine, thanks to HQO and all the organizers. Each speaker or team of speakers has 7 minutes, and they're going to be held to the 7 minutes, and I have the help of a timekeeper here who's going to keep us on that schedule. So it will be 7 minutes, and we're asking you to hold your questions until the end. So if you have that piece of paper, tablet, or whatever nearby, please make note of what you would want to ask, and we'll do that at the end of the session. So just to summarize for you, and as you saw, the learning objectives are to learn how your colleagues are translating knowledge into practice and the innovations which really have transformed healthcare delivery and promoted culture of quality. And one of the criteria for accepting the abstract was that there's evidence there was improvement and that's sustainable. So you know that you're going to be learning with that integrity in mind. And the other piece that's incredibly useful to take away is that of discussion and to get ideas and to, I think, challenge each other as well. So with that, I think we'll move on to our first session. And I will not be going into the bios. You have that information. But I'm pleased to introduce Sanaz Rio, who's with Ontario Shores Centre about EMR, Electronic Medical Record, and you're going to really appreciate this presentation. Over to you.
Thank you so much. So I wanted to start off by acknowledging my colleague, Dr. Ilan Fischler, who couldn't be here today, but very much a strong co-lead in the work that we've been doing at Ontario Shores. Here's our disclosures, none from me, and specifically some consulting Dr. Fischler has done. Give you a brief description of who we are at Ontario Shores. We are a teaching hospital specializing in comprehensive mental health and addiction services. We have approximately 326 inpatient beds, and we serve over 60,000 visits annually in our outpatient services, and we have approximately 1,300 employees. We provide a recovery-oriented care to a spectrum of populations at Ontario Shores, from our adolescent and dual diagnosis to our we have a large adult psychiatry program, a large forensic program, and we have our geriatric and neuropsychiatry program as well, with some specialty services in our outpatients. And that we are a Meditech 6.0 platform organization. We're fully integrated both in our inpatient and outpatient services, and that we recently achieved our HIMSS MRAM Stage 7 designation, placing us first in Canada. And really the main purpose of this presentation is really highlight how Ontario Shores has been able to leverage technology to really advance a lot of our quality improvement initiatives, and identifying the possibilities that are coming to fruition have been as a result of being able to be where we are in our HIMSS standings. Just to give a brief highlight of what around stage 7 really means, what we needed to be evaluated against was the notion of being a paperless organization, really demonstrating that we're using the data that's being entered into our electronic medical record to do analytics, find issues, and be able to really advance care from a patient safety quality of care perspective. And that they hold us to, or the criteria they hold us to, is there are some specific categories around CPOE, so computerized physician order entry, that has to be greater than 90%. Our medication scanning and ID scanning of patients by nurses has to be greater than 95%, and those are expectations that needed to be there for us to get that. And some of the benefit realizations that organization that is stage 7 designation and us that we're starting to see is around how we're able to continue to enhance quality of care, being able to really have abilities to measure effectiveness of care from some discrete data that we're seeing in our system, which I'll share some of that today with you. Continuing to advance our patient safety with using analytics, and then increasing access and efficiencies both for our patients and for our clinicians, and really being able to leverage on evidence-based technologies and integrating our evidence-based tools and integrating them into our technology to be able to reduce variability and advance adherence to evidence-based practices. Some key highlights around how we've leveraged on technology has been our CPOE, as well as our bedside medication verification, so that's around the scanning of medications and patient ID bands, as well as the systematic implementation of our clinical practice guidelines. And I'll briefly speak to one of our initial ones that we implemented around assessment and treatment of schizophrenia in mental health care in our inpatient units. But that this is a 5-year journey for us, where we, as an organization, we're year 3, and we've been implementing 2 clinical practice guidelines within the organization, across the organization, and leveraging on technology to integrate that within the hospital. Some of our results is our CPOE, so you can see that based on some of the strategies that we have implemented, our physicians have sustained between 94 to 96% of the time entering their own orders within the electronic medical record, really aligning with patient safety. Similarly, our nurses are scanning the medication and patient ID bands above 95%, and we've done some quality improvement initiatives to be able to identify, based on the information that we're now able to get from technology, that you can see before March 2014, we couldn't reach our target, and by really doing some analytics, being able to identify the issues, we were able to resolve some practice and process. We were identifying practice and process solutions to be able to then sustain above the 95% target. Another advantage that we've been able to realized is around creating a dashboard for our clinical practice guidelines. And what you see on the screen is a dashboard around for our schizophrenia assessment and treatment of schizophrenia. And not only do we have it at a corporate level, but we've broken it down, those reports, to provider level. So each physician monthly receives this report of how many patients do you have, and how many of them that have, for example, diagnosis of schizophrenia, and then breaking it down to all of the indicators we've identified for adherence, as well as outcomes, and how their performance is. And you can see that spider graph actually identifies their performance against the rest of the hospital. And we've done this now for almost a year, and our physicians are now ready over the next month to de-identify their, or not de-identify their name. So all of that information will be quite transparent. All physicians can see how they're performing and know who is who and their performance. This is just one example of some of the clinical decision supports that we can build into our system to really then reduce variability and make it easy for clinicians to do the right thing around evidence-based practices. So, for example, the physician on admission can identify if they're contemplating to start an antipsychotic for a patient. Based on that answer that they've said yes, it then triggers an order set for our pre-initiation for antipsychotics, and then all the evidence-based orders around metabolic monitoring and our lab tests or investigations will be predetermined, and the physician still has the opportunity to make unique decisions based on their clinical expertise and the patient as well, but that at least it's there for them to be able to be prompted around those evidence-based practices. Based on timelines, I'm not going to go into too much detail about the adherence rates, but we can see since we've implemented our clinical practice guidelines that we've had an upward trending, and now we're at a stage where we have the opportunity to be able to pause and start breaking down the information and do some data analytics to identify why we have some ebbs and flows in some of our monitoring or adherence rates, and then be able to then identify some QI strategies to improve them. The processes for us has been quite a multidimensional approach. It's not just about technology. Technology is an enabler for us. It's about how do we create pervasiveness of use, make it meaningful for the end user, be able to have some governance around monitoring our data and indicators to be able to support our clinicians in advancing care and adhering to evidence-based practices. Some of our clinical transformation strategies around really being able to enhance quality of care and patient safety has been around disseminating adherence results across the hospital and at different levels, so at the corporate level as well as at each provider level. And then through our physician team, they have some QI initiatives and having some discussions around some of the issues that they're seeing or cases that they're having. Having the opportunity to be able to customize our templates in our electronic medical record has allowed us to really be able to advance evidence-based practices and really reduce variability. And again, giving our staff individualized feedback has been quite helpful and very much a culture shift for our clinicians. Some of the key lessons learned has been having that consistent open communication with our clinicians around using data from the EMR to enhance quality of care and patient safety. So it's not about pointing fingers around competency. It really is around quality of care and patient safety, and the data is, we're trying to be transparent around those notions instead of it being around competency, and developing infrastructures for opportunities to be able to have surveillance around this data and be able to have a loop back feedback for our clinicians as well. Thank you so much.
Thank you very much. And our next speakers will be Mark Pham and Tai Nguyen, who are going to be talking to us about choosing wisely at North York General Hospital. And the title of the presentation, Putting Data in the Hands of Providers, Rethinking More is Better, Gaining Traction in Health Organizations.
Hi, everybody. So Mark and I are going to be talking, I'm going to talk more of the national picture, and Mark will give you a local example. And so we have no conflicts of interest to disclose. So choosing wisely is part of a global effort to demystify this idea that in healthcare, more is always better. In fact, the idea of overuse as being a major issue has become something that's quite global in scope. The US, for example, the Institute of Medicine reports that about 30% of healthcare there is unnecessary or does not add value. And I think we're pretty close here in Canada, as I'll show you in the next minute or two. So Choosing Wisely is a national campaign. We're a grassroots campaign to help physicians and patients engage in conversations about unnecessary tests and treatments, and to help them make smart and effective choices to ensure high quality care. We're funded by the Ontario Ministry of Health and Long-Term Care, but also the CMA, the Canadian Medical Association, as well as a consortium of other partners. So how does it work? Really simple. So all physicians belong to specialties, and these specialties are organized along the lines of these national societies. So if you're a cardiologist, for example, you belong to the Canadian Cardiovascular Society. So we go in and work with those societies to ask them to do very simple things. Identify 5 things that are commonly done within your specialty that's not supported by evidence. So this is a list, for example, the top 5 list from CSIM, the Canadian Society for Internal Medicine. And here's an example of what that number 5 recommendation looks like. So don't routinely perform pre-op testing for patients undergoing low-risk surgeries. Why is this a problem? This is the data that we just compile, our evaluation team, led by Sasha Bhatia at Women's College, around overuse of pre-op testing and low-risk surgeries. So these are surgeries that have to do with cataract removals, hernia repair, knee arthroscopy, endoscopy, those types of things. Very low risk. You do not need an ECG before surgery in most instances, but you can see the line here. The provincial average in Ontario, it's 30%. So this represents 2.2 million tests, 2.2 million procedures that we've analyzed over the last 5 years. So a significant proportion of those surgeries involve pre-op testing ECGs. What's even more remarkable is the institutional variation. So each of those dots represent a hospital in Ontario. So there's close to 150 of them. And some of them are really high performers, about 3% pre-op testing ECG to about 89% on the other end. So huge variation. So I think there's something that we can do to bring that variation down and bring down the average. Why does this matter? Obviously, beyond the waste argument, this is, we live in a finite resources environment, but also these types of tests can lead to really bad outcomes for patients in terms of unnecessary exposure to radiation, for example, and not to mention the false positives and all the things that go with that, the psychological impact that goes with that. So I'll turn it over to North York General, one of the organizations across Canada that are kind of putting these guidelines into practice.
Great. Thanks, Ty. And thanks, everyone. So at North York General, we picked up the Choosing Wisely mantle in May 2014 and have spent the last year and a half really focusing on how do we kind of embrace the evidence that Choosing Wisely Canada and its partners in the US have put together and really kind of push on that focus around evidence-based practice. We had a number of key levers in place already. We just heard about the importance of order sets, and we have quite an extensive order set library and CPOE in place that really helped create a good foundation for this work inside the organization. And we took really a four-part strategy around it, looking at firstly getting our most senior medical leadership on board to really drive the discussions and change with all of our clinical chiefs and physicians across the hospital. We put evidence into people's hands, so not only the evidence from Choosing Wisely Canada, but also insights that have been gathered over the last year or so between the lab, medical imaging, physicians who are delivering care at the front lines, and put that into hands of all the physicians around the hospital to get them thinking about what are the top 5 things they would suggest stop doing. Do they agree with the Choosing Wisely recommendations? Are there other ideas that they think would be really important to focus on for improving the care for our patients? And with all the kind of ongoing communications and blogs and everything else, I'm watching some of the tweets coming through for today, those same kind of social media strategies as well. We built up a real momentum inside the hospital to focus on how we can reduce unnecessary tests, procedures, and really focusing on our core vision and value as a hospital, which is really putting patients first. So we've had a number of great successes so far. We're still working on both spread and scale. I think back to Danielle's message this morning. So we've seen through the efforts a reduction in 40% of our lab testing in the eMERGE. So this means that 1 out of 3 patients no longer get any lab tests in the eMERGE after clinical assessment, and the patients who are still get fewer tests than they were before. We've picked up the mantle on pre-op testing that Ty has just talked about, and the team there, and I really give credit in each of these cases to the clinical teams who led this work, but they've reduced, they re-examined their entire matrix for those very stable patients undergoing low-risk surgeries and have reduced their pre-op testing by 40%. I'm picking on the lab, but certainly we've seen it in ECGs and elsewise. We've continued the push around inpatients as well. So we've built on our inpatient order sets to reduce lab testing, reduce CT testing, reduce ongoing kind of standing order x-rays out of the ICU. And we've also tried to absorb the spread from others. So Catherine's going to be up, I think, in a bit, talking about the great work that UHN has done around the medical imaging consult line. But we've borrowed that idea as well and tried to learn from others. So we're constantly trying to engage with others across the field and learn from others around what's next in terms of choosing wisely and how we continue to push. So we have a number of efforts still underway, and happy to talk about those after the session today. I'll hand it back to Ty just to talk about what's next for Choosing Wisely Canada. Oh, sorry. Oh. And this is just, if anyone wants to see the real data, as Wendy said, there's real evidence behind it as well.
It's pretty phenomenal because North York General operates one of the busiest emergency departments in the country, and they've managed to get 40% reductions in unnecessary tests there. So we have a number of organizations like North York General that are popping up across the country, really a groundswell of activities, very grassroots kind of led efforts led by physicians locally to put the Choosing Wisely recommendations into practice. So they include Halifax on the east side of the country all the way to Vancouver Coastal on the other side. And you actually have some of the postcards on your chairs there highlighting some of these efforts that are going on. But one of the things that we want to do now is to build on that momentum. And so we're launching this challenge called the 10 Million Challenge. And the idea is to help prevent 10 million unnecessary tests and treatments by the year 2020. And if you have time, please pop by our booth right at the entrance of the exhibit hall downstairs. But it's really simple. Register with us and you get some profile on the website. You get a really simple starter kit to get going. You pick a target, you implement that over the next year, and you tell us how you did, and we'll net that against the 10 million. So hopefully this can happen by the year 2020, and we'll reach our target. Why don't I just end there, and I think we can take questions, or feel free to pop by our booth. And Dr. Wendy Levinson, who chairs Choosing Wisely Canada, is actually giving a talk this afternoon as well. So I've given you the condensed version, and I think she's going to speak at greater length about this. Thanks.
Thank you very much. Great gains being made. Next, we have Dr. Darren Larson, who's going to speak to us about enhanced EMR use. So we're going to be hearing some of these pieces are going to weave together quite nicely. In the name of the presentation, the title, Advancing the Quality Agenda by Realizing the Potential of EMRs Using Technology to Transform Care.
Thanks, Wendy. So welcome, everyone, and it's my pleasure to be here in front of all of you today and talk a little bit about some of the successes we've had in the world of EMRs and implementation of EMRs in the province of Ontario. Well, I guess I should move past them onto me. Disclosures, I am the Chief Medical Information Officer for the company called Ontario OMD, and also for the association, the Ontario Medical Association. Ontario OMD is a wholly owned subsidiary of the OMA, fully funded right now by the Ministry of Health in a new agenda, which I'm going to explain to you in a moment. We have had a really great time in the last 7 years of putting EMRs into doctors' offices in the community, and it's been successful. I mean, successful to the point that we now have about 85% of our primary care doctors in Ontario with electronic medical record systems in their office environment. We got there through a consistent approach, a proven framework of applying peer leaders and change management teams and field teams in individual practices to help doctors implement their EMR and then get going. And going from getting going to getting good, the next step then, of course, is from good to great. So as we've evolved and we are no longer funding hardware and software in physician offices, we're now moving into this world of enhanced use and the next phase of maturity of EMRs. So it comes down to this: how do you show if in a practice environment you're working with a mature system or not? We have developed a model for maturity which allows us to measure. In other words, you can't change what you can't measure, as we've heard over and over and will for the rest of the day. We have a model now which looks at about 7 domains of practice around a scale from 0 to 5, with 0 still being paper-based use and level 5 being very high-level population-based health within individual practices for individual EMRs. This maturity model has become the maturity model that's been adopted by the Canadian Association of Health Informatics. You're going to see this being used across the country right now, and we're quite proud of that. But when we do a model, what does it mean? How do you actually put this into practice in each individual environment? And to scale that and to spread it, we actually developed what's called the EMR practice report. So you can go online as a clinician and go through a survey that looks at 25 different questions and lets you choose where you are now and where you think you want to be. So in real time, you get analysis on your practice's use of your system, and as well allows you to identify gaps in use of your EMR, and then allows you to focus more deeply on 1 or 2 or 3 of those gaps for quality improvement. This is a big deal for practices. When you get a heat map like this and you start looking at where you could be making improvements, it's a little bit daunting. So we don't just want to cast this on people and say, go to town, do what you can do. We want to help them get to the next level. This is a quick look at maturity on the 3,500 physicians in Ontario that have been through this process now. There are 11,600 plus doctors with EMRs. 3,500 have done the model, and not meant to read any of the detail, but to say quickly, when looking at color codes from red to dark blue, we can see where effort needs to be put. And we're scaling pretty well on implementation. We're not doing very well on provincial connectivity and integration. So how you get there? Sorry, this is a bit covered up, but we now have field teams, about 55 people in the field who are change management experts, and we've just now rehired and hired in 60 peer leaders in the Ontario MD Peer Leader Program who are physicians, nurses, nurse practitioners, and clinic managers who can go into clinics one by one or do more group-based interventions that allow you to look at the gap in where you've identified in your practice you want to work with, and then actually produce changes within the practice using online tools, all kinds of collateral that we have for education, and then group learning processes. So this is an example of the 400 or so interventions that have happened up till now. The three of them are in, the three big areas are practice management, information management, and patient results management, no big surprise. But if we look at where groups want to put effort at the beginning, we're still dealing with things like nomenclature and data quality and consistency. If you've looked at an EMR, you know for sure that the quality of the data we have in there is not particularly good. We have people putting smoking status in problem lists. We have putting them in progress notes. Sometimes we're putting them in the places where the smoking status should be. We've got prescriptions that are different. We have all kinds of ways of coding or non-coding. But when we apply a consistent approach to changing that, through the program we call EMR Practice Enhancement Program, we see the bar being raised. And in the quality improvement cycles, it's all about getting to a new level. We don't really care where you are, we care about where you want to be, and we want to help bridge that gap with that field team peer leader approach. So how do you do it? Basically, you run the EMR maturity tool at the beginning, you consult with your practice advisor, and every practice in Ontario has a practice advisor. Identifying the gaps and minding those gaps, looking at priority areas for change is the most important piece in this meaningful use journey. The focus interventions with the practice advisory consultants, the peer leaders, and others are where we begin through the classic PDSA cycle, kind of looking at quality improvement. And then you watch and you measure and you show change and you go back and repeat and you show improvement over time. But achieving maximum maturity requires integration, and this is no easy task, as any of you who have worked in the EMR space understand. To do this well, we need to connect, and connecting means getting all kinds of provincial assets in play. Good news is, in the new arrangement with Ontario MD and the Ministry, Ontario MD has been given responsibility for some of these integration projects. So we are advancing OLIS uptake in individual practices now. Hospital Report Manager is delivering reports directly from hospitals into EMR environments. We have finished a pilot project for e-consult and are moving into the space of e-referral. We're developing an EMR dashboard, which we hope to deploy in the next year, showing data quality and quality measures from individual EMR instances that can be used for improvement. E-booking is coming in our domain. And then we're working with eHealth Ontario and other major provincial assets like the Drug Profile Viewer, potentially e-prescribing, the Connecting Ontario Strategy, CSWO, CNEO, and CGTA, and then Diagnostic Imaging Repository. These are eHealth assets. It will be our job to help EMRs connect and work with those eHealth assets. So next steps for us, we want to link this kind of work to system quality improvement measures. And this means working with Health Quality Ontario, looking at how we might take practice primary care performance measurement indicators and embed them into the work that we do. We're looking at preparing for greater uses of data quality and data regarding clinical decision supports. That's working with OMA on their proposed program called Insights for Care, Data Analytics at the Bedside. We want to be responsive to the primary care changes and potential accountability structures that we're going to be hearing about today. And I'm on a panel this afternoon with Dr. Martin and David Price and others looking at primary care moving forward. Going to be interesting times. But ultimately, we want to focus on improving patient care. And when it comes right down to this, all of us work in front of patients every single day. Our ultimate goal is to be the best doctor, nurse, and provider that we can be. And Ontario MD is there to help you move the bar. So on that note, I'll stop. Thank you very much.
Thank you very much. Excellent talk. Following up now, we have Laura Williams with us, and Joanne Mitchell is not with Laura, so Laura will be handling this on her own. And she's from Holland, Bloorview Kids, and we'll be talking about a consumer health portal, I think a direction many of us are taking. So it's titled Engaging and Activating Families in the Implementation of a Consumer Health Portal.
Thank you. And yes, Joanne is not here today because she has a cold. And we thought coming to a healthcare conference with a cold is not a good thing. Would not get many smiles about that. So I'm here to talk to you today a little bit about Connect to Care. Connect to Care is a consumer health portal that we have developed at Holland Bloorview in partnership with funding support from Canada Health Infoway. And so just briefly, Holland Bloorview is a children's rehabilitation hospital in Toronto. We are Canada's largest hospital, seeing over 600 inpatient admissions a year and approximately 60,000 outpatient visits. So why did we want to develop a portal? Well, a couple of things. Our clients and families were coming to us after we adopted an electronic medical record platform, saying, okay, you've got the platform, now we need and would like easy access to our information. And they wanted that from home at any time of day, not just when our business hours were up and running, but usually when they had free time, it was later in the night, middle of the night. We know how busy our patients and families can be. They also wanted to have access to everything in one place. They wanted to be partners in care, to have ease of access to information so that they could then take that and use it in the other health systems that they are part of. Openness and transparency, improved communication and efficiency. So we saw this as an opportunity to partner with our clients and families on understanding and providing better care. Sorry, there's a little fly here. Providing better care to our children and their families. So the project really was to further empower our families to take an active role in their care, implementing this consumer health portal that was integrated into our existing Meditech system, and again in partnership with Canada Health Infoway. So after working with our patients and families to understand, and I will share with you that our journey changed as we went along, as we heard about the elements that would be most important to them. So where our project started and where it ended are a little bit different. And what project features they said would be most valuable were being able to view their clinical documentation and printing those documents to be able to take to other providers or to have them at home, not to have to go through the health records department, mailing in checks, visiting, all of those pieces. They wanted to be able to view their appointment schedules and cancel and request functions as well through the online platform. Again, we were hoping and are seeing an opportunity here to reduce no-shows or last-minute cancellations through the use of an electronic portal, and having secure two-way messaging systems with our clinicians. So we talk about email and is email secure. Many of our clinicians are doing it, but it also then allows for the two-way communication to happen over the portal. There is a record, and there doesn't need to be this extra step of documenting the discussions that are happening over the portal. So just to let you know briefly, we do have a client and family engagement strategy at Holland Bloorview called our Family Leadership Program. We have about 150 volunteer family leaders who come to our table and advise us on all aspects of care. So we had a natural pool of individuals who could help us develop this system. And when we started this process, we knew that we needed to engage them from the very beginning to avoid developing a system that essentially didn't work or didn't meet their needs. And had our family advisory committee involved at the pre-funding application level, so they sat with us on calls with the ministry and with Canada Health Infoway to talk about what would be valuable to them. We then had focus groups, large group discussions, and this is where the meat of the portal was really decided. And these are where the changes were implemented from what we thought would be helpful to really what they wanted to see most importantly. They were on our vendor selection team. They were part of the project team through this whole process. They were on our change team, or are on our change team, our steering committee. We held our first pilot with our family advisory committee. And one of our family center care specialists is here, Amir Carmeli, who helped onboard families. So we also had 2 family members, 2 family center care specialists who were helping to enroll families at all stages of the portal rollout. And finally, a research study. So we are evaluating not just a benefits evaluation, but understanding, is this improving the care that we are providing in our hospital? So I'm happy to report that we've had excellent enrollment, far surpassed our targets. We launched We received the funding in October, and we launched the portal in December. You know that for a technology solution, that's very quick. So we had our fingers crossed, and everyone was working very hard. Our target for the end of this fiscal year, so 1 year enrollment cycle, was 721 registrants. We now have 1,440 registrants to the portal. The users, so again, looking to see, are people actually using it? It's one thing to enroll, to have people interested, but are they actually using the portal? So our target was around 2,200, and we reached 3,700 uses to date. So it is valuable. People are using it. They are going on and implementing. The other piece is having patients and families involved and gathering their feedback as we went along has allowed us to be nimble. So I'll give you an example. As we rolled out the portal, we had a system where new notices and new appointments, families would receive a notification to their email, clients would receive a notification to their email. So we have inpatient clients on our unit, and the notifications came through at midnight. And so, teens, they have their phones by their side. It dings whenever they get a message. I have an 11-year-old, and I have to take his phone out of his room so it doesn't wake him up in the night. And a mother came to us and said, my daughter doesn't want to say anything to you, but I've experienced and witnessed the phone waking her up, because on an inpatient unit, you are changing schedules, you're getting new notices daily. And so by hearing that from the family member, who also was going home at night and sleeping at home, but had that phone beside her bed in case something happened to a child in the middle of the night. So she was also getting woken up. And we know that for care, for the caregiver and the client, they need sleep. It's one of the things they don't get a lot of when they're in the health system. And so by bringing us that feedback, in 2 days we were able to make a switch, and now the notices go out at 8 a.m. in the morning, so a much more reasonable time. But what it does is it demonstrates that these solutions also need a nimbleness inside of them and an opportunity for patients and families to provide feedback as they go along and as we see what the user experience is actually like. And so just to share a couple of quotes from our patients and families. Reviewing my history reminded me of how much Holland Bloorview has been part of our lives. We're so grateful. Families who go back now and see the journey that they've been on. When you're in the system, you may not always be aware of how much you've gone through to date, and also being able to recapture and see where things are going. This is amazing. I can show this to my coach, and he can plan my training accordingly. This is a high-performing athlete who then was able to take the information back to his coach, easy to access, and they could continue to plan together. And then finally, I can't wait to get rid of this binder. So families have a lot of information. So those who experience chronic illness, those who have children with disabilities, those who are in the medical system have to gather and keep information. And this was one family's binder, and she said, great, I'm going to get rid of it because it's all now online, easy for me to access. Oh, and that would be all. So happy to take questions after. Thank you.
Thank you very much, Laura. Okay, and next we have Dr. Melanie Rebello and Mr. Amir Afghan, who are going to speak to us about e-consult and the impact, reducing the need for face-to-face consultations. And this is from the Champlain area around Ottawa, and the title of the presentation, as you can see, Lessons Learned in Provider Engagement, a key factor in the successful adoption and utilization of the Champlain-based e-consult service. Over to you, Melanie.
Thanks, Wendy. So today I'm going to speak about the lessons that we've learned in provider engagement as we've gone about implementing the Champlain-based e-consult service. I have no disclosures. So e-consultation came about as a potential solution to address access to timely specialist advice for primary care. And the challenge that we were facing as we were implementing this was how to get healthcare providers to try out this new technology. So today I'll be talking about the key features of the service that have led to high adoption and satisfaction among PCPs and specialists. So following our proof of concept, which we launched in January 2010, an enhanced version of the service was relaunched in April 2011 and has been operating since. We've seen accelerated growth in terms of the number of registered PCPs. As of the end of September, we had just over 700 MDs and 130 nurse practitioners who were registered. And what's been really interesting about this growth is that it's happened very organically. It can really be attributed to providers spreading the word about the service to their colleagues. And these comments are coming directly from our PCPs and attest to that. We started off with 5 specialties and we're now at 80, and we've achieved this growth primarily through PCP demand for new specialties and by specialists coming to us directly because they felt that their patients were waiting too long to be seen or were being seen unnecessarily. How does the service work? Well, a PCP logs onto a secure site where they fill out a form to choose a specialty from a general list, and they're then presented with some more specific options. They submit the case, and it gets assigned to a specialist based on their availability or rotation. That specialist answers within 7 days. There can be some back and forth conversation, and ultimately the PCP closes the case. So now I'll talk about the features of the service, and it's important to keep in mind that these are all rolled out as part of a managed service, meaning that we're approaching things differently than simply leaving the technology and the process in the hands of the individual to figure out. We found that physician engagement, specifically identifying clinician leads who can act as champions of the service, has been really important for us. They were the ones who got things off the ground, and they're the ones that we turn to whenever something needs to be addressed. We aim to keep all aspects of the process as simple as possible for our users, and one of the ways that we do this is by having a common form for all specialties with very few required fields. PCPs submit the case to a specialty rather than to an individual specialist, and that reduces the uncertainty over making the appropriate choice and eliminates the guesswork involved in figuring out who's currently available to respond. Joining the service is also straightforward. There's no cost involved. All the individual needs is a device that can connect to the internet and to commit less than 30 minutes of their time to going through an orientation session that walks them through the process. We've also come up with a novel compensation mechanism for our specialists that they've been happy with. No individual billing is necessary. The system tracks and generates payment on a quarterly basis. To ensure that PCPs can count on receiving high-quality responses within a certain period of time, we established a target response time of 7 days, and we provide proactive support by having a very responsive technical support hub that's able to process issues like password resets very quickly. And we also actively monitor our usage data so that we're able to identify and pick up on issues before they become issues. We built in a survey as part of our closure step, and this allows us to provide ongoing feedback directly to our specialists and is a huge motivation for them to continue participating. Through the survey, we're also able to identify needs or gaps that lead to enhancements in the service, and we do have providers that are taking advantage of our flexible system design and are integrating e-consult within their own internal processes and workflows to reduce wait times. So the combination of these features means that we're seeing new users actively seeking us out to participate. Here you can see accelerated growth in terms of the volume of cases that we've processed. So we've seen our initial number more than double year over year, and this year we're projecting completing over 6,000 cases. Here you can see our top 6 specialties, and we do have cases submitted across all 80 services. Our specialists have been fantastic and extremely supportive of the service, and this really shows in their response time. So on average, they're answering consults in 2 days and sometimes in 5 minutes. Here you can see a list of our specialty services. So at this point, it's a very easy decision for the PCP to use eConsult because they know that they'll be able to access the specialty they're looking for. One of our survey questions asks our PCPs to identify the outcome of the consultation, and what we're seeing consistently over time is that over 2/3 of cases don't end up in a face-to-face visit with the specialist, and in 40% of these cases, a referral is no longer necessary, so that means about 4,000 patients aren't ending up on a wait list. Another survey question asked our PCPs to identify whether they got confirmation of a course of treatment they had in mind or something new that they hadn't considered. And in 60% of cases, they're telling us it was something new, but in both scenarios, whether it's reassurance or new advice, PCPs are letting us know that in about 95% of cases, the consult is providing them with high or very high value. The kinds of comments that we're getting back from our PCPs are about learning through the process. Patients are also learning about the service, and they're really delighted to be able to get advice from a specialist without needing a visit. It's great to see the love of e-consult being referenced, and ultimately what we really want to get to is highlighted by this quote, where PCPs are looking at e-consult as their first choice in determining a course of treatment or need for a referral.
Thanks, Melanie. Just a couple of points to emphasize as we wrap up. The success of this project, let me just jump over here. The success of this project had a lot to do with clearly defining the problem, which was access to specialist advice in a timely way, and having a simple and effective approach to being able to address it. Having the physician champions and also having a reliable service that the PCPs could count on was really key. We're also engaged on a number of fronts to explore further enhancements and spread for the project, starting with the ministry-funded provincial pilot that Darren had also referred to. That's been running in a number of regions over the past 9 months, and we've been working particularly closely with Ontario MD, the Mississauga Halton Lynn, and OTN to be able to explore opportunities to extend the reach and the benefits of this service elsewhere in the province. There are also some national collaborations that are going on between our research teams and their counterparts elsewhere in the country, so stay tuned on that. It's really important to also emphasize that this really was a true collaborative effort between a number of organizations you see listed there. So the Champlain Lynn, the Ottawa Hospital, Winchester Hospital, which is a small hospital sort of in a rural area south of Ottawa, and also the Briere Research Institute. Funding really was from seed funding that started with the Ottawa Hospital Academic Medical Organization, subsequently the eHealth Ontario folks in 2011 who helped us sort of expand that, and the Champlain Lynn sustained it until the ministry basically stepped in January of this year and has been funding the service since then. And we also would like to acknowledge a couple of our other co-authors, Dr. Keeley and Dr. Liddy, who couldn't be here with us today, but they are also our physician leads. Thank you very much.
Thank you very much. Okay, and then finally, we're moving over to Dr. Heidi Roberts, who's going to talk about a strategy in which she's been able to be a leader in decreasing emergency department visits, improving appropriateness of imaging, and so on. And this is titled 1-800 Imaging Pilot, Building Partnerships Between Primary Care and Medical Imaging.
Thank you. So I'm the sole presenter of a team effort. Supposed to be presenting with me today is Catherine Wang, our executive director, who apologizes that she can't be here today, but she's the driving force behind it. And this project mainly originates from medical imaging. Again, there's a whole team behind it that is sitting all over there, and I'd like to say a special thank you to Karen Weiser and Lily with him, who are really the ones who are doing all of the groundwork and the data collection behind it. I said it is kind of originating from medical imaging, but this project stands on two main legs. The one big pillar is Women's College Hospital. The other one is the SCOPE initiative. And big thank yous and big nods to our supporters, Danielle Martin and Paul Pariser, who've been invaluable in getting this going. We have nothing to disclose. So the background is that if you talk to community physicians what they think about medical imaging, they say mainly, well, it's really difficult to get into specialized imaging. We don't really know how to get in there, what to order. We don't really know whom to call. We don't have access points. And if we get a referral somewhere, it takes a long time until the patient finally has an appointment. So if I really need some imaging done urgently, I have no other choice than sending the patient to the emergency department, which is definitely not the right way to go. So we try to address this, keeping in mind the aims of the three pillars of the triple aim: the decreased per capita cost, improved population health, and the improved experience of care. Does the improved access of imaging somehow fit into this triangle? So we developed a project, got a nice name, 1-800-Imaging, and the project went from May 2014 to March 2015, March of this year. Participating were 60 primary care providers that were registered in the SCOPE program, who agreed to participate with us in this initiative. The objective was to assess the impact of this navigation hub, if you want to give it a different name, on the number of emergency visits, because this was our main outcome. Can we decrease the number of emergency department visits? And can we influence the appropriateness of imaging that has been requested? So basically what that is, the 1-800-Imaging project is a hub. It's a navigation hub, consists of a call center that can be accessed by the primary care providers. It is designed to improve the integration to medical imaging, make it seamless, make it more appropriate. It's supposed to be easy, one contact number, and you get right away to the right people. And it's a clerical staff that answers the phone, no voicemail, they answer the phone and they coordinate the different calls into different directions. And this is depending on the actual question that a primary care provider may have. Could be an appropriateness. I have no idea, should I do a CT or MRI in this case? It could be a consult saying, I don't understand this report, and it could be from our institution or from somewhere else. It could be that they want to accelerate imaging, and the definition of urgent is very wide. It could be that the patient already had the exam and I'm still waiting for the report, just facilitating the reporting, or general information. Does a patient with shellfish allergy has contrast allergy as well, just as an example. What we measured in this pilot are the call volumes. How is the appetite in the community? Are people actually calling in? Which services of the ones that are just listed are actually accessed? And do people catch on to it? Are they repeatedly use it or just trying it once? And the other outcome measures were, are we actually reducing the number of emergency department visits? And in the pilot, we simply asked, what would you have done if the patient if you wouldn't have had access to the hub? Would you have sent the patient to the emerge? Then also the improvement in appropriate imaging, and then of course the improvement in the patient and provider experience. So these are the number of callers that we had in blue during the pilot phase, and then just to show that it's actually continued in green once we had transitioned into operation. So we had an initial peak, people were trying it, word of mouth spread. We had some higher numbers, but they're leveled and they didn't go further down. So really most people who called got hooked and they kept on calling. We had 78% unique callers, but also quite a few repeat callers. So people were actually pleased with the service provided and they called again. The services exit, they are kind of listed here. Majority urgent imaging, just trying to get the patient into the system, followed by general information, and really that could be kind of anything that has to do with medical imaging technology, questions surrounding any kind of imaging that should be done. Appropriateness consult, again, what kind of exam do you think I should do next? And less common, actually, the radiologist consult and the urgent reporting. Number of emergency department visits used, we had 40 logged in our system. So 40 providers said, if you would have not been able to get an appointment through you, I would have had no other choice than send my patient to the emergency department, which is almost 40% of the urgent imaging calls. The improvement in appropriate imaging was reported in all of the appropriateness consults, so people felt more comfortable and changed their mind in which kind of imaging to use. And the last outcome measure, the improvement in patient-provider experience, we did log a couple of comments, and I just cite a few that saying the service was efficient, it was wonderful. Both the primary care provider and the patients were pleased. They reported that the service is excellent, who helped in urgent cases to triage the patient into different pathways. Or they said it's spectacular, and cannot remember a time since I was a resident that I could exercise such a great service. So the comments were really very supportive. So the challenges and lessons learned. The challenges are that we just have. It's very difficult to actually quantify the success and the outcome both for the primary care physicians and for the patients, and we're working on that. The other challenge is to reconcile this initiative with the appropriateness and the choose wisely that is going on. Lessons learned, well, the primary care providers actually appreciate they have direct communication with the radiologist, whether it is to actually get information or just validate what they already thought they would do. It's very helpful for them to get reassurance. And we need integrated guidelines that ensure appropriate, equitable, and the efficient use to actually not clash with the appropriateness guidelines. So next step, and where are we going from here, just following up what you heard from Daniel Martin this morning. This is a pilot, and it's the pilot that eventually will lead to system solution. The next step is to go wider. So we tried to redesign the entire imaging journey. This pilot was more focused on the primary care provider, but we also want to look on the patient side of the experience. So we're going wider and deeper. And this is currently being launched again by the Joint Department of Medical Imaging that we represent in combination with Women's College Hospital, the SCOPE project, and we're branching out, for example, to Tattle Creek Family Health team. Thank you very much.
Thank you very much. Excellent presentations, and I commend the speakers for sticking to the 7-minute time frame, which is tough, but extremely well done. We're now open for questions and encourage you to come forward, and if you would introduce yourself and also identify to whom you would wish to direct the question. Who's brave? Very clear. I wonder if the speakers have any questions of each other. Is there anything from hearing each other that you would want to raise? Oh, we have.
Hi.
Thank you.
Hello. Just around the choosing wisely, wondering, you showed the data that on the screen in relation to the decrease in certain tests. Just wondering if you can speak to the outcomes of not doing the tests. I think we heard that this morning around, what if we find that cancer? What if we do this? Are there any data that you can share with us around not doing those tests?
So outcomes really has been the hardest thing to track. So we looked at it from a number of ways. We had a patient advisor with us right from the beginning to try to get a sense of how patients define those outcomes. And what they shared was it'd be very difficult to go to patients who didn't ever get a test and say, how did you feel about not getting that test that your doctors just changed their mind on you don't need? So it was difficult from a patient perspective. What we did was, on the patient side, we really tried to track how have satisfaction experience scores changed in those areas where we're making dramatic change, and we haven't seen any negative impact in terms of experience scores or satisfaction. So it's trying to triangulate around it. From a pure clinical outcomes perspective, it really has also been two factors. One, anecdotal from a physician surveying perspective to understand have they seen changes. We've looked for have there been add-on tests. So if we reduce lab tests in the eMERGE, should we see add-on tests because the physician then decide they did need that extra testing, or did that patient get readmitted more frequently for some reason? So we haven't seen those indicators, but true outcomes have been very difficult to track. So we've really been trying to triangulate. Ty, from a national perspective?
Yeah, just really quickly. So the recommendations, so we have about 150 recommendations. Every single one of the recommendations are based on evidence. So they were selected based on previous studies that have been done to suggest, for example, that pre-op testing in low-risk patients do not create any kind of clinical impact whatsoever. So they're all based on evidence.
Thank you. Another question. Yes.
Yes, for the same gentleman. I'm very interested in diabetes. I was wondering if any of your tests that didn't get done were related to diabetes. Do you know offhand?
So I would say the only one we weren't testing as frequently was glucose, which we decreased the volume of that testing, but that was the only ones. I'm trying to think we were really.
So bedside testing, you mean?
Well, this was testing the eMERGE. If I think about back to bedside testing, we didn't change what our current kind of processes were around glucometer use, et cetera. I don't know, Ty, if there's anything on a national level specifically on diabetes.
Yeah, I think there was a list that was produced that relates to diabetes patients. So please check out our booth.
Okay,
a bit more of a marketing plug for us. But please come by, and we're happy to talk.
okay, super, thank you.
Thank you. Yes.
Hi everyone, I'm Melissa from North York General. My question is for the presenter from Ontario Shores about achieving HIMSS Level 7 status. Congratulations. I'm from North York General. We're very close. We're at Level 6. And I'm just curious as to your advice for us in terms of getting to that level and sustaining the change once we get to that level.
So that's a fantastic question. I think for us, it was a journey of really having our staff recognize that advancing the EMR wasn't about technology. And so we really incorporated, so implementing our clinical practice guidelines and building a lot of order sets. So meaningful things that really helped integrate evidence-based practices was how we created adoption, and then giving data back to the clinicians again. So adoption was a big thing for us because when we implemented, we did a big bang across the whole organization. So right from our 2010 implementation, our entire organization was live, but it was really working towards adoption and engagement of our end users. That was really what we worked on over the years.
Thank you. Any other questions? Okay, let me just summarize briefly what I've heard, and I think you will be able to reflect on this as well, but there's a number of themes which have really come through incredibly strong. Oh, you have a question. I'm sorry.
Yeah, I'm working in a long-term care home. So I just heard they have a record EMR. And then do you have any plan that to connect your system to the nursing home so we are not necessary to call the unit nurse to update our residents' condition?
I'm not sure if that question was for me or not, but I'll take a stab at it. Just to mention the EMR space that Ontario is involved in is actually in physician and nurse practitioner offices in the community. The job of connecting the EMRs and long-term care institutions to the HILE will be not our domain, but is in the domain of eHealth Ontario and their larger connectivity strategy. So if you get a chance to look at the eHealth Blueprint for Ontario, which was just published, the refresh was published in November of 2014. There is certainly a space there for a linkage of long-term care institutions, both chronic care hospitals and the standard nursing homes, and potentially even where much care is happening right now in the seniors community housing sort of projects and or the retirement homes that have various levels of care built into them now. So ultimately, those kinds of systems need to connect just as a community-based EMR would to truly integrate the system. So keep your eyes open, and when you get to the connecting projects that eHealth Ontario is actually getting out the door right now through Connecting Ontario, CGTA, CNEO in the Northeast, CSWO in the Southwest, we're starting to see the ability to view a larger data set on an individual patient that comes from the hospital environments, primarily linked into the lab information system, eventually the diagnostic imaging repository, and at some point, when community-based EMRs merge into that, then we will also have the ability to see a broader data set from the care of that patient prior to them going into long-term care or institutional care. So it's coming, not just from us, but we are part of a bigger piece of puzzles.
Thank you very much. Pregnant pause. Yes.
Hi, I have a question for e-consulting and also for 1-800-IMAGING. Anybody can answer. I was just curious about the accountability and just from a legal perspective in terms of the giving of advice. Who is ultimately responsible for that decision or the decisions that are being made in those situations?
So, excuse me, for the e-consult one, CMPA actually has a statement on that actually for the physicians. It's important to note that the primary care provider is still the most responsible person. They will consult and get advice from the specialist, and they can decide how to apply that advice for treatment for their patient. And in some cases, in our service in particular, the specialist may never actually know the patient. They don't need to know who the patient is specifically. They can, based on the information that they receive, determine that this is not adequate and the patient does need to be seen by a specialist, or based on the advice that they have, or the information that they have, they can provide some recommendations. This is not totally new because there is guidelines for hallway consults and telephone consults. The difference here being that actually everything is documented and transmitted electronically, so it makes it a little bit easier for tracking purposes as well.
Great. Thank you. Any other questions? Okay, just briefly in summary, there's a few messages that came through to me, and I'm sure you heard them as well. Just going through what I heard, technology as an enabler, and I think we heard phenomenal initiatives here with amazing positive impact on quality of care and also on the clinicians and those involved in the care provision, which is quite measurable. The value of feedback, clinical dashboards, having open communication. I think when Mark and Ty were speaking, the issue of more is not always better. I think many of us intuitively have known that for a long time, but how do you get a handle on it? And how do you start getting this under control? And quite impressive work with choosing wisely and the goal of decreasing variation and so on. And I think the experience of North York is a lesson for all of us, and seeing a 40% decrease in emergency department lab testing is pretty impressive, decreasing use of chest x-ray and ICU down 20% and so on, so an impressive initiative. And Dr. Larson in his speaking was the focus truly is on improving care, and that's what we're hearing throughout. We are all here to look at how we can improve care. I was impressed that you mentioned that 85% of the physicians actually have adopted EMR, which is a really impressive step. And the issue of maturity modeling. Reference to spread and scale, we're hearing repeatedly. It's being mentioned by a number of our speakers here today, but also you heard that earlier. So spread and scale is what we're all committed to doing, and how do we get the good news out there and share it? It is about quality improvement and how we connect with all the assets. Laura spoke about Connect to Care. I think that's a great acronym for the site, and the Consumer Health Portal. What you've heard in every presentation is engagement of the patient or consumer within the work that's gone on to ensure its relevance and it meets the needs. And very clearly, this is a very impressive initiative. The other thing we've heard about is partnership, whether it's with Infoway, whether it's with another organization, whether it's with another specialist group or whatever. None of us can do this alone. Partnerships are where it is at. And I think the statistics Laura shared are absolutely impressive. That usage to date is 5 times what their target was. And they're really achieving that and moving forward in a very impressive way. eConsult, a really amazing initiative. That's from my area of Ontario, and I had a sneak preview of some of this previously, but it's absolutely very, very impressive. And to get the specialists to buy into that kind of role, I'm sure had its growing pains. But clearly the impact is a win-win for everyone. In particular, it's about improving care. In particular, about timely access to the specialists, decrease wait time, and be able to provide higher quality care to those for whom we are here. And lastly, Heidi, I think that particular initiative is not dissimilar to the access to eConsult of getting that specialist advice and specifically focusing on imaging. And a word we heard several times, success was due to simplicity. Simplicity in the approach, being responsive, and ensuring what was put in place really was something that was reasonably easy to use and focused on what the overall goals were. Thus, on your behalf, I just want to thank our amazing presenters for the impressive initiatives which you've had underway and will continue, and urge all of you to learn from that and take back what you can to your own organizations and to help with the spread and scale. But on your behalf, I'd like you all to thank our great presenters. Thank you.